دكتور يسري باسم دكتور يسري اللي قبلها. يس ايوه. اهلا وسهلا بحضراتكم مره تانية. الحقيقه انا بقول المحاضره دي on behalf of my professor يعني معلمي الفاضل الاستاذ دكتور يسري عقل. اي اسئله هتبقى في الاتجاه ده، الحقيقه مش في الاتجاه ده خالص يعني. I will talk about the sarcoidosis, which is a mysterious disease really, and pulmonary hypertension. As we all know that sarcoidosis, this is an immune-mediated disease precipitated by something unknown. We don't know, that's why it is a mysterious disease. It's have susceptible genetic background affecting multi-systems by a non-causating granuloma. As we all know that the granulomatous inflammation and fibrosis in the pulmonary vasculature can affect the airways, the interstitium, and other anatomical location, may end into pulmonary hypertension in a significant number of patients. As we see here in this cartoon, واضح تماما إن هو affect multi-center. It can affect the eyes, primarily the lungs, sure, and the lymph nodes, the eyes, the heart, liver, spleen, the bone marrow, parotid, the CNS, the skin, and so on. And it seems from this cartoon that we have some racial differences in the percentage of the affection of each organ. So sarcoidosis-associated pulmonary hypertension, which is known as SAPH, WHO in 2013, they consider sarcoidosis one of the group 5 causes for pulmonary hypertension, which means I have maybe pre-capillary disease or post-capillary disease or both or unknown mechanism. And it's one of the systemic disorders classified under the group 5 pulmonary hypertension. زي ما حضراتكم شايفين, this is the pre-capillary, which is group 1, 3, and 4, and the post-capillary, which is the group 2, or the unknown mechanism, which is the group 5. And it is mentioned to be a rare disease. Is it rare حقيقي ولا لا? So the epidemiology, sarcoidosis-associated pulmonary hypertension, its prevalence is from 5.7 to 28.3 of all cases of sarcoidosis. So it is not rare in cases of sarcoidosis, and may reach up to 73.8% in patients referred for lung transplantation with end-stage lung disease. Number 2, it has high morbidity and high mortality. Why high morbidity? Because I have increase in the oxygen requirements of the patient with more functional disabilities related to the sarcoidosis itself and the affection of the other systems. And high mortality, and strikingly, it was 7-fold increase in the mortality between the patient with sarcoidosis associated with pulmonary hypertension and those with end-stage lung without pulmonary hypertension. So the different mechanisms that's known for the SAPH was the pulmonary vascular infiltration and obliteration, altered flow dynamics due to the bulky lymph nodes, the lung fibrosis, and cardiac sarcoidosis. So the proposed pathogenesis, we have a PEM vasculopathy. PEM vasculopathy means I have granulomatous inflammation involving the whole layer of the vessel, leading to the changes and remodeling, which is similar to that of the pulmonary arterial hypertension. So I may have a patient with sarcoidosis, but it's really in the pathology similar to pulmonary arterial hypertension of group 1. I have entemal thickening, I have medial hypertrophy, adventitial irregularity, and endothelial dysfunction. Also, I may have cardiac involvement, and then up to 25% of patients with sarcoidosis having silent affection of the heart, and only 5% have manifestation. ده في منتهى الأهمية، والريفلكشن بتاعه is very important. Whenever you have a case of sarcoidosis, لازم ندور ورا العيان ولازم نسكرين for cardiac affection, and this is very very important. كتير بنشوف العيانين الساركويدوزس عنده lymphadenopathy والعيان بينهج ومش لاقيين حاجة في البارينكما. We should put in consideration إنه هو he may have cardiac sarcoidosis which may be the cause of this dyspnea. علشان كده the screening for the affection of the heart is very important in sarcoidosis. Sarcoidosis may cause myocarditis, myocardial infiltration, and finally cardiomyopathy. It usually causes conduction disorders, ventricular arrhythmias, heart block, heart failure, whether heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. بيبقى عندي البوست كابيلاري element بيبقى واضح فيها جدا جدا. بنلاقي بقى الويدج بريشر بتاعنا عالي، علشان كده بنعرف ان this is a post capillary element. And we may have interstitial lung disease وانا برضو احب يعني اسمع راي اساتذتنا فيها. الحقيقه في الانترستيشال لانج ديزيز كتير بنشوف العيان الانترستيشال لانج ديزيز associated with sarcoidosis and this patient is not that hypoxic like that of the HP. تمام؟ وبالتالي هو الهايبوكسيا is present but it's not that prevalent زي other diffuse parenchymal lung diseases like the HP. However, if we have hypoxia, we have hypoxic pulmonary vasoconstriction, we have destruction of the pulmonary capillary bed, بوظنا الاركيتكتشر تماما, we have inflammation and we have increase in the incidence of the sleep disorder breathing. ينتهي في النهاية كل ده إن هو يعمل لي VQ mismatch. And we have a proposed chronic thromboembolic pulmonary hypertension. This active inflammation may promote hypercoagulable state. وكان في بعض الاستاديز بترجح هذا الكلام. من ضمن الاستاديز دي سويجرس إيتال قال انه هو الحقيقه الاستادي دي شويه قديمه يعني هي كانت في 2007 بس هو عمل بوست مورتم ولقى انه في pulmonary embolism in almost 2.5% of the patients كانت في الستيتس من الديسندنتس اللي هم موجودين عندهم ساركويدوز. في اكتر من حاجه كانت proposing ان انا عندي ممكن يحصل لي incitothrombosis which may result in chronic thromboembolic pulmonary hypertension. Other mechanisms should be put in consideration. I may have marked thoracic lymphadenopathy and fibrosing mediastinitis, leading to architecture distortion of the major branches of the pulmonary circulation, ending in obstruction of the pulmonary flow. I may have cirrhosis, which is rare complication of sarcoidosis. الحقيقة ما فيش reports عليها بس this is a proposed mechanism for the occurrence of pulmonary hypertension. We have the chronic anemia leading to hyperdynamic circulation and increasing in the cardiac output which is concomitantly طبعا هيبقى معاها pulmonary hypertension and increase in the mean pulmonary artery pressure and may be induced also by the management or the treatment of sarcoidosis by the methotrexate or the azathioprine. And we have the extensive hypoxia that may cause due to the hepatopulmonary syndrome. This hypoxia may lead to manifestations of hypoxia and vasoconstriction of the pulmonary vasculature. And this is a summary that have been published in the ERS monograph for sarcoidosis in 2022. It's very good. We have 4 big axes. We have the vasculocentric, the granulomatous vascular involvement, occlusive vasculopathy leading to PVOD and idiopathic pulmonary arterial hypertension-like lesion. We may have thrombotic angiopathy, acute and chronic pulmonary embolism leading to a disease similar to that of the chronic thromboembolic pulmonary hypertension. We may have extrapulmonary involvement, affection of the heart, myocardial systolic and diastolic dysfunction. We may have affection of the liver leading to portopulmonary hypertension. We may have sleep disorder leading to group 3 pulmonary hypertension, and also we may have mechanical effect, the fibrosing mediastinitis and the adenopathy, which leading to vascular compression, and we have finally the fibrosis that we have and the architectural distortion of the alveolocapillary bed, leading to ventilation perfusion mismatch. في النهاية كل ده يؤدي إلى SAF, sarcoidosis associated pulmonary hypertension. So we have different phenotypes for the SAF. It may be group 1, زي ما احنا قلنا granulomatous inflammation or PVOD or liver disease associated. It may be group 2 due to affection of the heart. It may be group 3 due to the parenchymal affection or the sleep disorder. It may be group 4 due to incitothrombosis and may be group 5 phenotypic overlap of all of these. So screening for the sarcoidosis associated pulmonary hypertension is very important. الحقيقة عشان نعملها لازم تبقى في الحسبان. Clinician should have the low threshold of suspicion of sarcoidosis associated pulmonary hypertension. مش مركز فيها مش هتعرفها. ما انتش حاططها في دماغك مش هتلاقيها. يبقى احنا لازم نبقى حاطين في دماغنا انه الساركويدوزس كان اوكير اب تو ربع العيانين اللي بنشوفهم بيبقى عندهم ساركويدوزس associated pulmonary hypertension نتيجة affection of the heart. تمام؟ وبالتالي لازم ادور ورا الهارت علشان اتاكد. لو انا نسيت الموضوع ده هنسى. الناس كلها بتفكر دايما لما بتلاقي ان انا عندي parenchymal affection فبتقول انا ممكن ادور واعمل ايكو علشان ممكن العيان يبقى عنده عشان الانترستيشال affection ممكن يبقى عنده ايكو كارديوجرافي. Don't forget الهارت affection. Heart affection is present. It's present up to 25% of the cases of sarcoidosis. I should search for it. انا اللي ادور عليه. انا اللي اعمل screening. طبعا الحاجات السيمتومز المتعارف عليها ما فيش حاجه باثوجنومونيك، لكن نقدر نقول ان انا عندي aggravation of the symptoms, worsening dyspnea, signs of right side heart failure, chest pain, palpitation, exertional syncope, or signs of heart failure of pulmonary hypertension in the physical examination, or برضو deterioration of the pulmonary function testing, decreasing in the DLCO, the FVC, or decrease in the exercise tolerance of the patient, or hypoxemia or exertional hypoxemia. And we should search for TANI for cardiac sarcoidosis by echocardiography, CMR, or PET scan. So my take-home message, SAF is not a rare complication for sarcoidosis, and pulmonary hypertension increases the morbidity and mortality in sarcoidosis. ما ننساش المورتاليتي 7 times البيشنت اللي عنده sarcoidosis and end stage lung without pulmonary hypertension. Screening for pulmonary hypertension within sarcoidosis patient is important. Detailed assessment of sarcoidosis patient, including non-invasive cardiac assessment, is important for proper management strategy. And SAF may be presented with group 1, 2, 3, 4, or 5. Thank you.
شكرا جزيلا دكتور ريم على المحاضرة الرائعة دي.